Hello, my name is Harsimran Kalsi. I'm currently a PGY3 internal medicine resident at the University of Central Florida in North Florida Hospital in Gainesville. I'm pleased to present our study titled Efficacy and Safety of Repeat Endoscopic Submucosal Dissection for Recurrent, Synchronous, and Metachronous Esophageal Squamous Cell Carcinoma, a systematic review and meta analysis, which was recently published in Gastrointestinal Endoscopy Journal. Endoscopic submucosal dissection or ESD is a well established and guideline endorsed modality for the management of early stage, predominantly T1A esophageal squamous cell carcinoma, offering high resection rates while preserving esophageal anatomy. However, recurrent and metachronous lesions, particularly those arising at or near prior ESD site, pose significant technical challenges. Unlike gastric lesions, for which repeat ESD is more straightforward, the narrow esophageal lumen, reduced wall compliance, and frequent submucosal fibrosis elevate the procedural difficulty and risk profile in the esophagus. These recurrent lesions are increasingly encountered in clinical practice given the broader application of ESD, but robust data on outcomes following repeat ESD in ESCC remain limited. We aim to synthesize the current literature and evaluate pooled outcomes of repeat ESD in patients with recurrent cancer after initial ESD. We performed a systematic review and meta analysis in accordance with PRISMA guidelines. Five retrospective studies met our inclusion criteria, encompassing a total of 232 patients and 258 lesions. All patients had previously undergone ESD for esophageal squamous cell carcinoma and developed a recurrent lesion. All lesions located within or adjacent to prior ESD site defined as within 5 mm were classified as recurrent due to their unique procedural complexity. Our primary endpoints included en bloc resection rate and complete resection rates. Secondary outcomes included perforation, bleeding, stricture formation, and recurrence following repeat ESD. All five studies were retrospective in nature. One study was multi-center, the rest were single-center studies. The mean age across studies was 69.4 years and male comprised 85.4% of the patient population. Most lesions were located in mid and low esophagus, with relatively fewer lesions in the upper esophagus. The average lesion size was 12 mm to 20.4 mm, and most lesions only involved less than 50% of esophageal circumference. Procedural time ranged from 54 to 91 minutes. Our analysis demonstrated that repeat ESD remains highly effective in these patients. The pooled en bloc resection rate was 90.07%. The R naught resection rate was 79.59%. Perforation occurred in 5.21%. Stricture rate was 10.26%. Delayed bleeding was infrequent with a pool rate of 4.05%, and the pool recurrence rate following repeat ESD was 8.60%. Long term outcomes were favorable, with three studies reporting overall survival rates between 95 to 100%. These findings affirm that repeat ESD is a viable therapeutic strategy in patients with recurrent or metachronous early stage ESCC. That said, repeat ESD is not merely a technical repetition of index procedure. Fibrosis alters the submucosal plane and distorts tissue architecture, which compromises lifting, reduces dissection visibility, and increases the risk of complications. Clinically, repeat ESD can be offered to appropriately selected patients, particularly those with confined mucosal lesions. In contrast, patients with deeper invasion, poorly differentiated histology, or lymphovascular involvement may be better served by surgical or chemoradiation approaches. Ultimately, this study provides pooled outcomes that can inform pre procedural counseling, risk stratification, and post ESD surveillance planning. Prospective multicenter data are needed to validate these findings, stratify outcomes by lesion complexity and fibrosis grade. Furthermore, comparative studies between repeat ESD and salvage esophagectomy or concurrent chemoradiotherapy in specific risk cohorts would be valuable in refining treatment algorithms. I'd like to express my sincere gratitude to my co authors for their contributions to this study. We are also grateful to the editorial team at Gastrointestinal Endoscopy Journal for the opportunity to publish our work. and contribute to evolving literature on therapeutic endoscopy in esophageal squamous cell carcinoma. Thank you for your attention. I welcome further discussion and collaboration in this space.